you see by the dawn's early light what so proudly we hailed at the twilight's last gleaming, whose broad stripes and bright stars through the perilous fight o'er the ramparts we watched were so gallantly streaming, and the rocket's red glare, the bombs bursting in air, gave proof through the night that our flag was still there. Oh, say does that star-spangled banner yet wave o'er the land of the free and the home of the brave?
We have a program today that I think is extremely apropos for this group. I walked into to get my allergy shots yesterday, and there were two members of the Swickley Men's Club going through balance therapy. And I started to think, if people think the Swickley Men's Club and all these people that have balancing problems, they maybe think we serve whiskey here instead of coffee. But anyway, we have a lady here that treated either 4 or 5 of our members for balancing. And we asked her to come and talk about it today, but I may wind up give us a little more time at the end so you can ask her all the questions. I asked her if balance therapy or balancing problems came with old age. She said, no, younger people get them too. So, but I think it's more prominent in older people, right? Okay, guys, that's why I asked her to come. But with that, please welcome Helena Pingree.
Hello. Can you all hear me? No? Speak louder. Okay. Well, hold it close. Okay, there we go. So thank you for having me. I'm honored to be here. I am a neurovestibular physical therapist. My undergraduate training was at Duquesne University, where I got my bachelor's and master's degrees, and then I received my doctorate in physical therapy from Chatham University. I've been practicing for 25 years. I'm a local girl. I grew up in Glenshaw, so not too far. And today with me I also have my student. Please stand. Her name is Megan. She's with us. Thank you. Megan is in her final training, and she works clinically with me in my office, and she'll be graduating in December, right? Good. Okay. So I would like to see a show of hands. How many people have had dizziness or have thought they had vertigo? A lot, right? It happens. It's one of the most very common problems that we see in our patient population on a daily basis. Out of the 12 to 14 patients we see, sometimes half are vertigo patients. So we do see a lot. We'll go ahead and advance the slide. Let's see if it works. There we go. So my marketing people told me I have to put this stuff up. We can just fast forward. In general, I want you to all know that the presentation obviously is not a substitute for treatment, and we want you to make sure you've seen your physicians if there's any serious health issues. Dizziness can mimic many other problems, heart problems, brain problems. It's not just an inner ear problem. So today I will speak about inner ear problems, but please know that dizziness can be a sign of other problems. So that's really what this disclaimer is, to make sure that you know to check with your physician all the time. So I think it's important we understand how our balance system works, right? It's a very complex process that I tried to whittle down to about 3 things for us. We have to have very good vision, right? Everything we process is visual. What we take in, the environment around us, and our brain is processing that information for balance. If any of you have gotten up in the middle of the night, you recognize that if you don't have a night light on, you feel off balance sometimes. That's very important for falls prevention. Many of our patients visually need those cues for balance. Proprioception, and that's why the happy feet are up there, are for touch. We have to feel with our feet. I've talked to a few people already this morning who told me they sometimes can't feel their feet because they have neuropathy. That affects your balance also. Third, the inner ear. So our inner ears are for hearing, but we have these tiny little balance organs, and that's what I'm going to talk about today. Those balance organs are the motion detectors for our brains. They tell us where our head is moving. They tell us how our body is moving as we're getting around or lying down in bed or turning over in bed. So there's the brain, our master processor. So if you've ever had a problem with your brain, mini strokes or small vessel disease, people hear that often. If you have diabetes and you have other health issues, the circulation to the brain can be impaired. That can certainly cause dizziness, but it also impairs the brain's ability to interpret and process information from our eyes, our feet, and from our ears. My daughter's 13 and put all the special effects on for me. Okay, so why do we get dizzy? Like I mentioned, multiple reasons. So today, for our purposes, since I only have a short time, I'm going to talk to you only about the inner ear and positional vertigo and how that causes dizziness. Okay. So everybody wants to know, what is this BPPV when you see the doctor? Or they'll tell you you've got crystals loose in your head, right? They're not loose in your head or your brain, they're loose in your inner ear, and we'll talk about why. But BPPV stands for benign, meaning there's no life-threatening cause for this. It definitely affects your quality of life, there's no question. If you get up every time you stand up, you feel dizzy, or every time you turn over in bed, or try to get up in the middle of the night and you're spinning, it definitely affects your quality of life, so there's a burden. The good news is it's not a life-threatening illness, but it can be managed. Paroxysmal just means it comes on suddenly, without warning. It lasts about 30 to 60 seconds, and then it goes away. That is a distinguishing factor for positional vertigo. And for folks who have that, no, it really comes on by a change of head position, okay, or body position. So if you bend down, right, to tie your shoes, put socks on, you reach up into a cupboard, or you are trying to roll over in bed to one side and get out of bed, you may experience a spinning sensation. It comes on sometimes fast and strong, but then it slows down, okay? Vertigo is just generally a false sense of movement. So vertigo doesn't always mean the crystals. It can also mean that you're just dizzy. So in our English language, words mean multiple things, right? So when you go to see a doctor, they might put vertigo on your chart, but they might put that on there because you're dizzy, not because you have crystals, or you may actually have a problem with the inner ear and crystals. When I see the word vertigo, I think inner ear. But I want you to know it can have other meanings also. So, just a little lesson on anatomy. If we talk about the outer ear, that's our earlobe. When someone looks in your ear, they are only able to see as far as the eardrum or the tympanic membrane. So, from out to in, and I'll try and reach, I don't have a pointer. So, from out to in, this is about as far as people see when they look into your inner ear. The organ that I'm speaking of is the swirly organ that you see here. The big swirly part is actually the cochlea. The cochlea is responsible for hearing. If you have somebody who's had a cochlear implant, they have a little magnet back here, and that's because they put it near the bone that covers that cochlea. Nobody can see or touch the balance organ. It is protected by the skull. And if you take your pinky finger, it's no bigger than the tip of your finger. But the balance organ causes a lot of trouble for people. And if you take that pinky finger and rest it behind your ear, where your glasses kind of rest, that's where your balance organs are generally located. There's one on the left and one on the right, and they are separate from each other. Again, outside of the brain, so we call that a peripheral vestibular organ. It's not inside our brain, but it communicates with our brain. The three little canals that you see at the top, where you see semicircular canals, those are the guys that the crystals fall into, and they're also the little guys that we have to get the crystals out of. They are not supposed to be in those little canals. But don't think when they say they're in the canal, it's not the external ear canal, it's the deep inner ear. Okay. So what are the crystals? Everybody wants to know. They do serve a functional purpose. They are called otoconia, and they are little calcium crystals. They actually rest on a bed of tissue with little hair cells, and they kind of just prop on top of them. And those little hair cells are what send the messages to our brain when we tilt our head or move our heads. So they do serve a purpose. You can't just take them out. A lot of people have asked me, can you put Gorilla Glue in there? Can you get them out of there? No, they have to stay. So unfortunately, when they detach from those little hair cells in the inner ear is when we wreak havoc and feel spinning dizziness. And we'll talk about the eye movements that I see when my patients do have vertigo and crystals displace. So, it's a little cartoon. But this is going to show you in the inner ear, if you can press play, yeah. There's no sound, I don't think, with this one. But what you're going to see is those little otoconia. See how they fall out? That's what happens. You can play it again. It's a quick little video, but I think it's good. I often show people this in the clinic. See if we can get it. Megan's my AV girl. Let's try again. So they kind of sprinkle out. You know how when you shake a snow globe and they trickle down the snow? That's basically what's happening in the inner ear. Now I have a better video. Let's go on to the next one. You have to keep pressing it, Megan. So essentially, when they fall out, what ends up happening is they're moving through the canals in the inner ear. Inside those semicircular canals is fluid. The fluid in there is called endolymph, and while we are watching, trying to determine when we position test someone if they have vertigo, we can't see the crystals. I can't see in the inner ear. So what I look for is something called nystagmus. Nystagmus is a rapid beating of the eyes. There is a specific type of nystagmus for every individual canal. How do we diagnose it? Imaging will not work. The only imaging we have are MRIs of the intra-auditory canals, but they do not do that for people with positional vertigo. You will not see the crystals in that circumstance. Position testing, though, is what we do in the clinic as physical therapists. So we do make you lie down in positions that will provoke the dizziness because we're looking for nystagmus so that we can fix it. So again, specific test, if you Google vertigo or crystals, you're going to see this. You're going to see Dix-Hallpike, you're going to see Epley maneuver. These are the terms that we use to evaluate and treat vertigo. What's happening during those tests is that we are looking for nystagmus. Again, there's a specific eye movement for every canal. Left ear, there's 3 canals. Right ear, there are 3 canals. When I watch somebody for vertigo and test, I'm watching their eyes. Your eyes tell us what's happening in the brain, but they also tell us what's happening in the inner ear. So here's a great video. Again, if you ever come to be my patient, I do put you in these positions. It's a nice video. I'll let you listen in.
The Dix-Hallpike maneuver is performed whenever BPPV is suspected of causing a patient's dizziness. The head is turned 45 degrees and the body laid back such that the head is extended about 20 to 30 degrees. If BPPV is present, eye twitching called nystagmus will occur. Eye twitching that rotates is called torsional nystagmus. Side-to-side eye twitching is called horizontal nystagmus. Eye twitching that goes up and down is called vertical nystagmus. The Dix-Hallpike maneuver is then repeated on the opposite side. This maneuver should be repeated several times to document for fatigability. When performing this maneuver,
So, I'm sorry if it's too loud, I can try and lower it, but I was afraid you wouldn't hear it. So now you can hear it. But I'm also going to show a video here shortly that actually shows when I do this test, what's happening with the crystals and why that eye movement happens. Again, it's pretty cool that each canal has a specific eye movement. And that's the only way I know where those crystals are. All right, we'll try the next one, see if we can get it to go. What's that? No, it's a different one. So in this video, they're going to show you what's happening in the inner ear. The Epley maneuver is what we use to treat positional vertigo.
Normally, only with head movement does fluid within the inner ear also move, informing the brain that a head turn. However, should a crystal called an otolith gets displaced into the posterior canal of the inner ear, BPPV dizziness occurs. Fluid movement occurs due to the crystal rather than head turns, causing the brain to think movement has occurred even though none has happened. The Epley maneuver is performed to treat this posterior canal BPPV by trying to get the loose crystal out of the canal. This maneuver is started by turning the head 45 degrees and the body laid back such that the head is extended about 20 to 30 degrees. If BPPV is present, eye twitching called nystagmus will occur. After 30 to 60 seconds, the head is turned 90 degrees to the opposite side and held for another 30 to 60 seconds. The head is then further rotated another 90 degrees, accomplished by having the patient turn onto their side, which is then held for another 30 to 60 seconds. At this point, the head should be turned 45 degrees from the horizontal. When performing this maneuver, another individual can help with these position changes. The maneuver is then completed by having the patient sit up. So what's going on with these position changes? Essentially, the head is moved in such a way to manipulate the crystal to fall towards the canal opening. With each position change, it takes about 30 to 60 seconds for the crystal to settle into the most dependent position in the canal. If turns are made before the crystal has a chance to settle, the crystal may fall back the wrong way and the maneuver will fail. It's also important that the head positions are angled correctly or else the crystal will not settle to the correct position in the canal and the maneuver will fail. Also, if the position changes are done too slowly, the crystal may not settle quickly enough from lack of momentum and the maneuver will also fail. Once the crystal falls out of the canal, the dizziness should resolve if due to posterior canal.
So, I mean, I've seen a few of you, but has anybody else ever sought treatment for positional vertigo? If you have, you may have recognized this treatment. It is called the Epley maneuver, but just like each canal has specific eye movements to identify where the crystals are, we have specific treatments for each canal. So, the Epley maneuver is a treatment only for something called posterior canal vertigo. The Epley maneuver will not fix all types of vertigo. So dependent upon the assessment, what we see with eye movements, we then decide clinically which treatment we apply. So I just want you to know that the Epley maneuver is only one maneuver out of many that we utilize to treat vertigo. But this was a nice illustration because it shows you how head movements and controlled body movements with somebody doing it for you can get the crystals to go back in place. Now, I've had a number of patients tell me, well, I Googled it, and on YouTube they said to do a somersault, so I did a forward roll. And I said, I'm impressed that you could do a forward roll. I don't know that I would do a forward roll. But those are not medically certified treatments. So it is important to seek a medical professional. for someone to actually evaluate where the crystals are so we can put them back in the correct location. I've had a number of patients try some wild things that they've seen on YouTube, and they come in with some very complicated vertigo, and it's stuck. So it's easier for us to treat you if you just come to us, right? And that's not to say we just want people to come, but we want to make sure you understand that you seek the appropriate care. You know, you wouldn't go to the mechanic for a heart problem, right? So you want to go to a vestibular therapist for an inner ear dizziness problem, of course, after you've seen your physician, okay? So how do we test in our clinics? The device that we use does not look in your inner ear. Everything is watching eye movements. So eye movements, again, are called nystagmus, and they indicate where the crystals are located so we can apply the correct treatment. So this is what you'll wear when you come to my clinic. We have a little television. We have goggles that we put on. They look like scuba goggles, and we watch your eye movements. Those goggles have cameras that project the eye movements to a television screen. I think you can go to the next. So one last video, because this is the best way for you to understand. When you are spinning, if you see this woman's eye, you'll understand what's happening. This is her right eye. So the other thing is that when we're looking and projecting to the television, it's like you're sitting in the TV looking out to us. So what's right seems left and left seems right. So don't worry about that. But just notice that when I play the video, the woman's eyes are spinning. They spin while that crystal is falling through that canal. That's how I know where they are, and that's how I know how to put them back.
That's got good right there. Okay, I want you to dip your head down so you're looking into your lap. Sense a better reaction if anything happens. And can you scooch all the way to the right side of the table? Yep, right there. You should go into the reverse. All right, you pick your head up. Turn your head to the right. When I tell you to, you're going to lie down flat, letting your head extend back to the table. If you get dizzy, hang on for the ride, we'll go right into the reverse. Okay? Ready? 1, 2, 3, lie back. Right here. Eyes open. Woo. Oh, you're going. Oh, no. Oh, my goodness.
This is what happens.
I told you
The
to
eyes
see a show.
spin.
All right, so you do have right posterior canal, beep, beep, beep. All looks good. We're going to go right into treatment, and we're going to fix this up for you. All right? You have a pretty good case.
So when I see that, I know that specific eye movement or nystagmus is only present for the right posterior canal. The eye actually spins and twists torsionally on itself, pointing toward the right ear. So again, eye movements tell me what's happening, so I know how to apply the correct treatment. All right, so I could talk for hours about inner ear problems and balance and all the things that affect balance. So take-home message is, if you have positional vertigo, you know it because it comes on quickly and suddenly with a change of head position. It lasts about 30 to 60 seconds. And then once those crystals fall and settle, you don't necessarily feel spinning dizziness anymore. You just kind of feel a little off kilter. I like to use the word wonky. It's just, you know, you just don't feel right? Because those ears, those crystals are our motion detectors. When they're out of place, you feel off balance, right? The other thing to remember, positional vertigo does not cause an inability to speak or swallow. It will not cause numbness or tingling on one side of your body. It will not cause weakness. It only causes dizziness and a sense of feeling a little off balance. So if you have those other symptoms, again, dizziness can be a sign of mini stroke. It can be a sign of, you know, anything with the heart, cardiology-wise, not getting enough oxygen. There's lots of other reasons for dizziness. So by no means do I want you to think if you're dizzy, you only have vertigo. So if you have other symptoms, you absolutely must seek medical attention for those. So how do you get to see me? Funny or not, I thought, oh, I'll send it all electronically and not bring cards. I'm sorry I didn't bring business cards, but all of my contact information is embedded in this presentation, and I will have your leaders go ahead and send that out. You can also find me on the internet through UPMC. But in order to see us in the state of Pennsylvania, if you are of Medicare age, we do require a physician prescription. And then once you have that prescription, you are able to call and schedule an appointment. Some of your primary care doctors that I have relationships with are able to not make you come into the office if they feel that when you call in and you talk to them that they're confident your symptoms are related to vertigo. I do have physicians who just submit that order and then you can come to see me directly. But it does have to be have oversight from a physician, okay? So locally, these are the offices that I work at. Again, I grew up in Glenshaw. I'm a local person. One of my offices is on the corner of Route 8 and Mount Royal Boulevard. That's in Allison Park. It is the UPMC Primary Care Building. And then I also see patients in the Wexford office, which is a little closer to here. If everybody knows where they built the giant Allegheny Health Network Hospital, right across the street is the Waterfall Plaza. And that's where Ichiban is. People seem to know the hibachi restaurant. I'm in that plaza. So I'm local, and I work every day of the week, but I split time between the two offices. You can also always email me. All of my patients know if they have an episode of vertigo, and they can contact me via email, and I can help coordinate getting an appointment for them. So with that, I think I left enough time for questions. Yes?
I've seen with this Epler procedure
Yeah.
where someone takes a head and actually sort of shakes the head as they go through the motion for about 60 seconds. And I've done this on my wife, and it works
Right.
brilliantly.
So one of the doctors that is our educator in our physical therapy schools, her name is, that's okay. It's okay. Her name is Susan Whitney. She's trained all of us, and she's wonderful. We jokingly call that the Whitney Shake because it's one of the applications that if crystals are stuck, or if you want to make sure, you know how you shake a snow globe to make sure they've all settled? We want to make sure we get all those crystals. Once they have fallen, we have to kind of shake the head, not violently, it's very gentle. But yes, we do shake the head sometimes. Sometimes we don't have to, right? It depends on the patient and their presentation. You also said that you are treating your wife. We do train our family members and caregivers how to do this because BPPV never happens on a Tuesday at 1 o'clock. It happens on a Saturday night at 2 a.m. So if you're suffering, we want someone to know how to help you. But then, of course, we want you to follow up with us to check and help out. Good question. Anyone else? Yes? Right, so right now, as we know, and lots of research on positional vertigo, so you understand it's benign, it can happen anytime, at any place. Is there a preventative? There is no medication, and there is no treatment that will prevent vertigo from happening. What I do is problem solve with my patients. If there's a particular thing you're doing that keeps provoking it, such as I have a woman who I was just seeing recently who likes to blow dry her hair upside down. So she puts her head down and blow dries her hair, right? I have gentlemen who like to work on their cars and they put their head down and underneath things, and that provokes their vertigo. So I do problem solve to say you can do all of those things, but we need to modify the head positions to avoid provoking it, because it's not pleasant, right? It makes you miserable. So the answer is there's no preventative, but we do troubleshoot positions that provoke it and help you to modify that.
Good morning. I have a granddaughter who has nystagmus to begin with.
Yes.
How does it confuse the area?
That is a wonderful question. Thank you for asking. And Megan, I've actually taught her that. So we not only with this goggle test do just the position testing for nystagmus. When a person comes to see me, I do a full evaluation. So I will ask them to move their eyes in daylight. Look up, look down, look left, look right, because I'm evaluating for nystagmus. Eye movements are indicative of brain problems, but also indicative of inner ear problems. And one of the challenges for students, and even for myself as a practicing clinician, is to make sure that I am screening for differential diagnosis, making sure that those eye movements. So my question would be to your granddaughter, is that new? Right, that nystagmus, or have you had that all of your life? There are people who are born with congenital nystagmus. Once I know that, interestingly enough, if that person has vertigo, when I have them lie down and position test them, the nystagmus will be totally different if they have vertigo, because those head positions are only indicative of a specific canal. So her nystagmus is there all the time, but that position testing will elicit a different kind of nystagmus. Does that answer your question? Good? Yes?
Other than, a lot of us older people have trouble with our balance.
Correct.
No vertigo,
Correct.
nothing pathologic that I know of. Can you add anything to that?
Absolutely. So today this talk was all about dizziness and inner ear and positional vertigo. But as I mentioned in my first slide, balance depends on vision and proprioception and inner ear and our brain's ability to be able to interpret all that information. So one of the other things we treat on a daily basis are people who have complex balance issues. Maybe it's not dizziness or inner ear, but I'm working on their ability to improve interpreting that information from their feet, from the environment, standing balance, walking balance. And the other thing I didn't even touch on for balance is strength. If you have any weakness, any numbness or tingling in your legs, any cardiac problems where you're deconditioned and need to exercise, right, that's a part of balance. So yes, we'd be happy to see those patients. We treat them all day long as well. Yes?
Does buildup of earwax cause lightheadedness or dizziness at times?
So there are conditions where people have fullness in their ears, ringing or tinnitus in their ears. I'll talk about a little of that first before I talk about the wax issue. The fullness can be a variety of many different problems. One of the most common disorders that people report fullness in the ears with is Meniere's disease. Meniere's disease is something that's caused by a fluid fluctuation deep within the inner ear. It is not the external ear. So that can cause fullness. It can also cause ringing in some patients. Ringing in the ears is not indicative of a balance problem. You can have ringing without a balance problem, but you can have a balance problem and also have ringing. Again, differential diagnosis. Many of my patients see a specialist at the Eye and Ear Institute to distinguish that, okay? So that would involve audiology testing as well as diagnostic testing. But to speak specifically about earwax, earwax, again, is the external auditory canal. It is not a part of the deep inner ear. So if you have excess wax, you can have a feeling of fullness, and in some patients that can make them feel a little bit off balance, but wax itself is not indicative of a deep inner ear problem. Usually, if you have excess buildup of wax, there's a possibility that you have to see an ENT regularly or your primary care to have wax removal. But understand, in the anatomy, that is totally separate from your balance organ. Yes? In what respect?
The balancing issue.
Absolutely, yes. I thought you were asking maybe if dementia was associated with vertigo. So, no, in terms of dementia, the brain is a master processor. If you have Alzheimer's or early signs of dementia or some short-term memory issues, your ability to correct an imbalance is not as perfect as someone who doesn't have early onset of those changes, right? So dementia affects the brain and its ability to process information. One part of that is balance, right? So I do treat patients who have Lewy body dementia, Parkinson-related dementia, cerebral volume loss, where they also have some dementia, and forgetfulness. And what's interesting is that balance exercises require high-level brain function. So it's if you don't use it, you lose it, right? So stimulating the brain in that way can be very helpful for those with dementia, although it will not cure dementia.
Speaking of my wife here, as she moves further into dementia, it seems she has more of a balance problem.
Absolutely. So we do a lot of falls prevention, a lot of caregiver training, and there is conflicting research about whether or not we can help people with advancing dementia learn again and learn new things. But I think more importantly, what I do with those patients is I'm focusing on hopefully trying to stimulate those old pathways that are there. Our brain has lots of connections, right? Sometimes when we have dementia, it's like the brain forgets to use those connections, so it's a lot of repetition, what I call blocked practice, cueing the patient appropriately to help them understand how to move safely. They may not remember it the next day, but it's that repetition. Good question. Oh, thanks. They might. Sometimes I wear like swirly shirts and stripes, and all those different patterns make patients dizzy too. I like your checkered shirt. That's a good one, right? Any plaid shirts, argyle, they're all good for my patients who have visual, like motion sensitivity. That's another piece to our puzzle. We do treat patients for that. We cannot cure motion sensitivity, but we can hopefully improve your ability to balance and process that information.
I have a question.
Yeah.
Just a point of clarification. I've been through balance therapy 4 or 5 times. Last 6 months, now I have it again. Now, I don't need to bend my head to wash my hair. There's no hair
Good.
there. Am I doing some position with my head?
So you've actually had vertigo again, or just true vertigo. So again, I would sit down and talk with you and kind of go through your everyday activities and find out, hey, what's going on. For some people, it's just how they sleep at night. If you have recurrent vertigo, someone asked about prevention. Sleeping positions, I usually tell people try to have at least 1 pillow, sometimes 2 pillows. I don't want your head to be uncomfortable, but it's lying totally flat with the head extended. Like if you ever had to go get an MRI or an X-ray or anything like that, they put you on a flat thing and your head's like hanging back. When you sit up, sometimes that causes people to be dizzy. Going to the dentist, right? Everybody's mostly right-handed, so your head's turned to the right and they tip you way back. Well, guess what? That can cause the crystals to fall out too. So I really do sit down and talk to my patients and try to find out, like, what are you doing during the day that is causing it? Because I fix it and then it comes back, right?
So is there a possibility if you went through training, you'd identify what the problem is?
Correct.
Don't do it anymore.
Correct. We modify it. You know, people like to do yoga or chair yoga or stretching. Like, you know, if you want to stretch your back in the morning, I've also had patients say, well, I bend all the way down and reach for my toes, but then I get dizzy and spinny. So, you know what? You can lie flat or on a bed with a pillow and bring your knees to your chest and still stretch your back. So there's lots of ways to modify things that you can still do what you want to do, but not provoke your vertigo.
Did you say, or did I misunderstand, that you need a referral from a physician?
Yes. So anyone of Medicare age, which is everybody here, we have to have a physician prescription. That's a Medicare law. If you're younger than Medicare age, I do possess a license that is called direct access, which means I can see a patient without a physician referral for 30 days. but they reserve that for the middle ground, not the very young pediatric and not the older geriatric, unfortunately.
Can you tell me a gentle way if you're being treated by somebody in a competitive network and tell your doctor you want a script to UPMC?
You have freedom of choice, right? That's the big thing, especially in Pittsburgh. But yes, you're allowed. And the other thing, so it's a misnomer to think that if you have Highmark, you can't see UPMC, and if you have UPMC, you can't go to Highmark. There's a lot of laws about that now because of that competitive nature. If I have UPMC insurance and I want to see a specialist at Allegheny Health Network, I'm allowed to do that. Okay? Sometimes that causes maybe a higher copay or something, right? That's the unfortunate part. But just by the same token, if you have Allegheny Health Network, you can come see a UPMC person. We work for Centers for Rehab Services, which is a separate company, but it's under the UPMC umbrella. Sometimes the copays are a little bit different, but you are absolutely allowed to. We do accept Highmark and all insurances.
Any other questions?
Going back to the loss of balance as you age, I mean, if it's not weakness or loss of proprioception, is there some other thing that happens that creates this loss of balance? Because most older people I talk to, they say, yeah, I have a problem with balance. And
Well, right. So there's a normal aging process for every system in our bodies, right? The visual system, the inner ear, the brain, the sensory system. You know, we all joke and say it doesn't work like it used to, right? So, and even for me in my 40s, my body doesn't work the same way that it used to. So you just have to, I tell patients, use it or lose it, right? Number one, that's a big thing. If you don't move, the other thing I tell people is move more, sit less, because once an hour, you need to get up and change position. If you're sitting all day long, every time you get up to move, you're going to feel off balance, right? Our bodies are meant to be moving. So sometimes it's disuse, not even just aging, right? But generally, if you think about as you get older, you move a whole lot less. So that is why I'm a very big advocate for a regular exercise program. It's hard to get seniors to exercise sometimes because fitness wasn't a huge part, right? You were hard workers. You all worked hard. There wasn't a lot of time for exercise, but it is a key component in retirement for patients to stay healthy and active. So sometimes just moving makes a big difference.
John Radcliffe, where are you?
You lost me.
I don't want to turn too quick.
Good point.
Okay, Helena, great presentation. I'm sure it helped everybody here in the room to hear about these issues. So you can get a hold of this fine lady if you got any concerns. And with that, we'll end the meeting. Thank you.
Thank you very much.